like to introduce a new, becoming more close colleague of mine from out here in Minnesota, whom I did not know or know about until I got a chance to go over to the hospital where he's been practicing now for some time. Dr. Matt Precker has trained in the system and stayed as both an EM and an IM doc who works in critical care, helps with both education and taking care of patients in a variety of different settings across the health system. The most interesting to us is at the interface of critical care toxicology, and we're always excited to run into colleagues who are in the trenches doing the same things we are. And between just sharing some patients recently and having a connection from an already established toxicologist, Joanne Lace, and also John Cole and other folks here in the Poison Center, they suggested that we talk to Matt because he is becoming an important expert in the field of using ECMO in places other than the controlled setting of planning for cardiopulmonary procedures, but instead being ready to implement it in critical care and even at the level of the emergency department. And so he's going to talk to us today about the potential applications of ECMO to the care of the acute toxicology patient as soon as they land in our laps. Matt, thank you so much for agreeing to do this.
Thanks, Dr. Racemius, and I appreciate the opportunity to speak, and thank you to the college for having me. I do speak about ECMO from time to time, building on our experience here at Hennepin County Medical Center and other places I've trained. When I speak about ECMO, it's always a broad audience as far as experience and what background people have. So my talk will start pretty basic, and then we'll build on that, and at the end, we'll focus some on applications of ECMO for the poison patient or in toxicology environment. By way of disclosures, I don't have any financial disclosures. I'll talk about some specific ECMO equipment during these 40 minutes, but I don't have any stake in that equipment. As you know, ECMO is actually a non-FDA approved method of life support. It's approved for about 6 hours of use in the operating room or ICU, but past that, you're on your own. The learning objectives for our talk today, I have 3. I want to go through the components of an ECMO circuit because ECMO can be intimidating if you're not using it a lot, and to break it down into just 3 simple pieces I think takes some of that mystique away. We'll try to discuss the indications and contraindications for ECMO in general in the ICU, and then I want to focus again big part of the talk on describing the use of ECMO for poison patients who have cardiogenic shock or cardiac arrest. And there we're using ECMO in its most true form, analogous to cardiopulmonary bypass, called veno-arterial ECMO. So we'll focus on that a bit. By definition, then, ECMO is extracorporeal membrane oxygenation. It's important to know that ECMO is not a therapeutic endeavor. It's strictly supportive, and therefore we use ECMO to replace the body's heart and lung function as we try to bridge to important things like full recovery. ECMO can be a bridge to mechanical circulatory support in people with an irreversibly damaged heart, or to organ transplant in the case of heart or lung failure. The key with ECMO, and something we've really strived to do in our program here in Minnesota, is excellent patient selection. And with patient selection, we're trying to really maximize the benefits and minimize the harms of using ECMO. We're looking for patients who have reversible causes of heart or lung failure, and those patients' diseases should be refractory to standard, conventional, and definitely much cheaper management options in our ICUs or EDs. Just to highlight briefly, we do have an ECMO program that's been running for some time at Hennepin County Medical Center. Just looking at our last 2 years then, we've done about 28 cases, and I just want to highlight that the way we run our program is to have a specialty group of experienced ICU nurses be the ECMO specialist. So they're the ones managing the patient's hemodynamics as well as the ECMO pump. So we have perfusionists on call, but it's our nurse at the bedside as a critical care team we really rely on to be our eyes and ears and also the one managing the ECMO circuit. We do a mix of venous and veno-arterial cases, as you can see outlined there. All right. To get to the fundamentals of ECMO, I'm going to illustrate these 3 components of an ECMO circuit for you using a very simple diagram. So the first important part of ECMO is the pump. And a mechanical pump, is used to pull central venous blood out of a sick patient and to do things to it as far as gas exchange and then pump it back into that patient's body. These pumps that are used now have really been an advance in the last 10 or 15 years of ECMO technology, where now these pumps are very quiet. They actually use an impeller, which both sucks blood in and then pushes that out a different lumen. The impeller is actually floating above the pump driver, magnetically levitated above, which keeps this device very quiet and also very cool, so it minimizes hemolysis. These pumps last a long time, they don't clot very often, and they've really been a boost to both the duration of ECMO support we can seek and also doing it with the fewest complications. The second component that comes right after the pump is the heart and soul of ECMO, and that's the membrane oxygenator. Other people call this the bloody ventilator, because what a membrane oxygenator does is what our lungs do. It takes out carbon dioxide from the blood and it adds oxygen before that blood then returns to the patient. The membrane oxygenator we'll go into a little more detail in the next couple minutes, but it's a really fascinating device and is kind of analogous to a dialysis filter. The third component of ECMO I want you to remember are the ECMO cannulas. These are large bore plastic cannulas that are placed to both drain and return blood. And again, I'll show you some pictures of those as we go. But pump, membrane oxygenator, and cannulas are really what make up any ECMO circuit, no matter what device your hospital has. A couple key physiologic principles of managing a patient on ECMO that I think need to be mentioned. Blood flow is really key. Blood flow is analogous to how well you're oxygenating the patient. We try to shoot for blood flows that take up a majority of the patient's native cardiac output. So in adults, we're looking for flows would be ideal about 3.5 to 6 liters a minute, depending on your application. And the limitation to blood flow in a patient is really the venous drainage cannula. So this is the one I show draining from the internal jugular vein there. That's typically the bottleneck in the system. And the biggest drainage cannula you can have, the better your flow is going to be. The second concept I want to talk about is the sweep gas flow. So blood flow, again, oxygenates the patient. The sweep flow, which is just simply hooking up the oxygenator to wall-regulated oxygen in a hospital environment and blowing oxygen through that oxygenator, is how we sweep away carbon dioxide, or that's how we ventilate a patient. And so controlling the sweep flow ventilates the patient, will manage your carbon dioxide, which is important in a patient in shock or a patient who's recently recovered from cardiac arrest. All right, I want to go into a little more detail then about the oxygenator. In this photo, I'm showing you the back of a ECMO circuit we have here at Hennepin called the CardioHelp, kind of the newest generation transportable small ECMO circuit. Plugged into the back of it then is a cassette, and this cassette's disposable. It includes both the pump as well as the oxygenator in kind of one disposable unit. We're looking at it again from the back, and you're seeing this red diamond, and that's the oxygenator. It kind of has two sides and a membrane between them. If, as a toxicology audience, I know, at least my colleagues here at Hennepin, very interested in mechanism and like to look under the hood of things, so I want to show you what's inside that oxygenator. In this inset picture, I'm showing you what you would do if you sliced through that oxygenator and looked at it under an electron micrograph. So what they've developed now are very strong, very thin plastic membranes. This current generation is made of polymethylpentene, and they've actually made that polymethylpentene into tiny tubules, or almost like bristles of a broom, if you were to look at this with the naked eye. Zooming in on those tubules, then, you can see there have a hollow lumen, and what happens is that sweep gas flow goes through the length of this straw, through the lumen of those tubules, as the blood then percolates kind of perpendicularly or percolates around those tubes. So the blood and air never come into direct contact, but this polymethylpentene is thin and strong enough where diffusion can take place. And the surface area inside one of these oxygenators, which again is about the size of a napkin or so, a dinner napkin, the cross-sectional surface area for gas exchange is about 2 square meters, which is similar to the surface area of a dialysis filter, but much smaller than the native lung, which obviously has the surface area of a tennis court, at least about 70 square meters. Again, just another figure illustrating that countercurrent blood and oxygen flow. The other thing we put in the oxygenator to help the patient is temperature-controlled water. It doesn't contact blood or air, but goes by and can control the temperature of the patient very closely. All right, how do we start up ECMO then? It always starts with cannulation, and we have two options for cannulating a patient on ECMO. One is the percutaneous option, which is a dilatational Seldinger technique with serial dilators to get up to the size of the ECMO cannula. And then on the right of the screen, you see one of our cardiovascular surgeons cannulating in an open approach for ECMO, where they actually cut down and visualize, in this case, the femoral vessels, and you can see them securing an arterial and venous cannula on the ipsilateral side. For adults then, these cannulas are big. The arterial side, which returns oxygenated blood to the patient, is between 15 and 19 French in general. And then our venous drainage cannula for a single lumen cannula is around 20 to 25 French. Let me then describe how the position of these cannulas really determines what kind of support you're giving to your patient. And that really has to do with the goals of your critical care. So I made this simple diagram, and I'll see if I can illustrate it with my mouse. But I'm showing you here the heart and lungs in the center of the diagram, central venous blood coming to the cardiorespiratory system, and then oxygenated blood leaving. So I'm first illustrating veno-arterial ECMO, and this is really analogous to partial cardiopulmonary bypass. So this kind of grew 50 or 60 years ago out of what pioneering heart surgeons and perfusionists were doing in the operating room. They said, can't we take that heart-lung bypass machine and bring it to the ICU and support the patient's vital functions for a longer period of time than just an open heart surgery case? So what they did then was use an ECMO circuit like I showed you earlier. I'll illustrate that by the gray box. And again, the pump pulls central venous blood and then pumps it back, oxygenated blood into the patient. In the veno-arterial configuration, where you're returning blood to a big artery via the femoral artery to the aorta, the blood's actually got to flow retrograde back to the heart and lung unit. And again, so we're perfusing the coronary arteries and the brain in a retrograde fashion, which is not physiologic, but in patients who have very sick hearts, it works. The distal perfusion down to the legs is usually very good. We do have to be concerned with the leg distal to the return cannula. That can become ischemic because you've got a large cannula in the femoral artery, the end artery. So we'll often put a distal perfusion cannula pointing down that leg, again, to make sure we're getting perfusion ipsilateral to the cannula. This is what veno-arterial ECMO would look like as just a simple diagram of a patient. Here we're draining blood via a long 25 French venous drainage cannula placed in the femoral vein. It's going through our ECMO circuit, and then it's returning via the femoral artery. Here I'm just showing it on the opposite side. That arterial cannula is shorter, and again, it terminates somewhere in the abdominal aorta with retrograde flow back up towards the great vessels in the heart. All right, let's move on then, and I want to illustrate ECMO we use for where we don't bypass the heart and lungs, but here we actually just want to support the lungs, or an adjunct to boost gas exchange for failing lungs. This is veno-venous ECMO, or we'll call it VV ECMO. Here we're taking that ECMO circuit and we're actually putting it in series with the heart, not in parallel. So here again, ECMO always involves draining central venous blood, but here we're returning the fully oxygenated blood to a central vein, essentially to the right atrium, and then we're using the heart, the still functioning heart, to pump that blood to the body. So the non-physiologic part of VV ECMO is now you have red blood or oxygenated blood in the right ventricle and the pulmonary artery, where that usually hasn't picked up oxygen yet. Again, the body tolerates this fine, and the lungs can actually add some to gas exchange in this kind of configuration as well. Our two diagrams just illustrate how this can be done. Some ECMO centers really rely on a two-cannula approach, where typically you drain blood as you do in VA ECMO from a femoral vein with a large cannula, goes through the circuit, and then you return that blood, in this case, to internal jugular vein, and that cannula would terminate near the right atrium. So these two drainage and return cannulas are pointing at one another, raising the possibility of recirculation or less efficient circulation. What happens, the newest development then, is actually developing kind of a dialysis light catheter, which is a large dual lumen cannula that can be placed with just one poke in the internal jugular vein. Using ultrasound and fluoroscopy, this cannula can be placed into the chest, and the goal is to have the return lumen of this dual lumen cannula, which opens where I'm showing here, right at the level of the right atrium, so that blood is pointed right at the tricuspid valve, where these cannulas drain both from the superior and inferior vena cava via little side holes. So these dual lumen cannulas are large. In an average size adult, we try to place a 31 French cannula, and they do work quite efficiently. We've had good experience with them at our shop. All right, to summarize then, the ECMO cannulation. For VA ECMO, we're using that for cardiorespiratory support, so this can support a failing or failed heart. It bypasses the heart and puts the ECMO circuit in parallel with the heart. VV ECMO, on the other hand, is used for respiratory support only. You've got to have a functioning right and left ventricle for this to work. And here we're putting the ECMO circuit in series with the heart and returning that oxygenated blood to a vein, not an artery. This is what a dual lumen ECMO cannula placed in the internal jugular vein looks like. This is one of the patients we took care of here at Hennepin with severe ARDS just a couple years ago. This cannula, as you can see, I like this picture because it really well illustrates how the circuit's working. So here, blue venous blood is draining, and then what's returned after, post-oxygenator is very red arterialized blood. So it's a neat system. Let's then talk a little bit about general ECMO indications as we're moving towards the toxicology applications. So veno-arterial ECMO, to support a failing heart, we're looking for patients with potentially reversible cardiogenic shock. Those can be people with specific poisonings that we'll touch on later. Infectious causes like viral myocarditis, although rare, tend to recover. And then CV surgeons use ECMO a lot for people who have difficulty getting off of cardiopulmonary bypass in the operating room due to myocardial stunning. There are applications emerging in emergency medicine using veno-arterial ECMO in the ED in situations very specific, select patients with out-of-hospital cardiac arrest and favorable prognosis. And VA ECMO is used emergently to try to bridge that patient to the cath lab in lieu of external cardiac massage or CPR to open a occluded artery. So that's eCPR, and it's emerging, not ready for prime time yet, but a lot of active investigation. Looking at indications for respiratory ECMO or VV ECMO, the far and away the largest category of patients is severe ARDS. This can be ARDS from a whole host of causes. Aspiration, sepsis, or trauma are three big ones. And in ARDS, we often maximize our therapies we know help patients. Those include high FiO2 and high PEEP strategy, lung protective, tidal volumes, early neuromuscular blockade, prone positioning, sometimes inhaled pulmonary vasodilators, diuresis. All these kind of interventions are typically exhausted before we turn to VV ECMO. It also works as the oxygenator very efficiently removes carbon dioxide due to its solubility in blood, works well for hypercarbic respiratory failure, so status asthmaticus would be another accepted indication for VV ECMO if they're not responding to usual therapies. And then severe air leak syndromes as well, either post-surgical or traumatic large tracheal tear or bronchial tear. You don't need to ventilate that patient if they're on VV ECMO, and you can have time to support them and then repair the injury. ECMO has some relative contraindications, and again, this is a dynamic environment, so these are changing, but the ones I typically talk about are if the patient doesn't have landing sites for your cannulas, that's a problem. So someone with severe peripheral arterial disease who needs VA ECMO, that's an issue and may need to go to central ECMO or other creative strategies. Patients who you cannot safely anticoagulate are classically taught to be contraindications to ECMO. We'll come back to that because we've had some success at Hennepin. I know other centers have too in running ECMO for a week or two without any anticoagulation. So that's a relative contraindication. We're looking for patients who would benefit and have a good quality of life and duration of life after ECMO support to use this resource-intensive intervention. So people with multiple organ failures already, like dialysis patients, end-stage cirrhosis, people older than age, say about 75, may be looked on less favorably as candidates. Metastatic malignancy would obviously fit in life-limiting comorbidities. Those are cases that are best not put on ECMO, in my opinion. For VA ECMO, if a patient has aortic valve insufficiency, that makes the retrograde flow of blood up the aorta difficult to support their hemodynamics. It can lead to refractory pulmonary edema. And then in the respiratory ECMO world, we want to get to people early. We don't want to be pounding their lungs with high-intensity mechanical ventilation for longer than a week, because we know outcomes get a lot worse after that. So we've got to make that decision to use ECMO, again, when we have salvageability, but it's not too late. For just a bit of history, this photo illustrates the first successful published adult ECMO run. This is a patient that actually had trauma as the reason for ECMO. He crashed his motorcycle in California on the Coast Highway near Santa Barbara and was brought into a center there and had some serious injuries, long bone fractures, a traumatic aortic tear. Went to the operating room, had those injuries stabilized. But then in his postoperative course, by day number 3, he developed fluid overload and shock lung and ARDS, and they were unable to oxygenate the patient. So they actually called just down the road to UC Irvine, where one of our pioneers of ECMO, Robert Bartlett, was developing different membrane oxygenators. And so they were able to acquire one of his kind of prototypical ECMO systems, which I'm showing here and the blue arrow illustrates, hook it up to the patient, support gas exchange, anticoagulate very heavily with bleeding complications and others, but got this patient through it, and then wrote it up in 1972 in the New England Journal of Medicine. We've advanced quite a long way since then, and keep that mental picture of the ECMO circuit there in mind, because this is what we use now. This unit is very user-friendly. It has ultrasonic alarms. It will measure non-invasively flow and hemoglobin and mixed venous oxygen saturation for you. And it also can be carried with one arm. It weighs about 11 kilograms. I want to transition then in the next 20 minutes or so to talk about ECMO for toxicologic emergencies or poison patients. This is an area I'm really excited about. I really enjoy working at a place where we house the Minnesota Poison Control Center and have great consulting toxicologists to work with. What we've noticed and I've read about is that just as indications for ECMO in general, cases and centers are growing by the year, so are the number of poison patients that are requiring ECMO, as reported to our international registry, the Extracorporeal Life Support Organization. I think this is underrepresenting the total volume of ECMO for tox indications, but here you're seeing between 2006 and 2014 a really exponential rise in cases. This is what we found in veno-venous ECMO for adults, respiratory ECMO. Coinciding in 2009 with the avian influenza epidemic, we had people we just couldn't manage with standard mechanical ventilation, one on ECMO, and had great success, and that kind of really allowed a lot of investigators to dust off ECMO as a reasonable technology and look into it a lot more in adults. There are select drugs or overdoses that I think are reasonable to consider ECMO in, and here I'm preaching to the choir. I'm not an expert in this, but just to illustrate for you, cardiovascular active drugs would be natural ones. Beta blockers, calcium channel blockers, or class 1 antiarrhythmics that block at sodium channels can all cause cardiovascular collapse and could be rescued with ECMO as the body metabolizes these overdoses. Tricyclic antidepressants have been described to have a role with ECMO support. Select SSRIs like citalopram and other antidepressants, bupropion is one that comes to mind, are indications as well that can really cause refractory hypotension, cardiogenic shock. And then chloroquine, through a number of mechanisms, including sodium channel blockade and refractory arrhythmias, has been rescued with ECMO in the past. This list is longer, but I'm just highlighting kind of the most important indications. And I'm going to present a couple of cases in just a few minutes that we've managed with ECMO, also to illustrate that, as you folks know, these overdoses don't come in isolation often. And so beta blocker plus calcium channel blocker can give you a physiologic picture that can be challenging ECMO, but is salvageable. There are a couple of issues related to ECMO and the circuit and the oxygenator that I think are important for toxicologists to think about. You all have exciting and a lot of enthusiasm for other rescue therapies besides ECMO. One that we think a lot about is lipid emulsion therapy. The deal with lipids in ECMO has been controversial. The perfusionists, again, the folks that work mainly in the operating room with cardiovascular surgeons and a heart-lung bypass machine, are very cautious about lipid emulsified drugs or infusions mixing with their membrane oxygenator. I think this is a little bit myth and a little bit reality. We've had ECMO patients here at our shop be managed with propofol infusions with no decrement in gas exchange, and the oxygenator didn't catastrophically get clogged up. But again, I think intralipid therapy, if it's given before a patient goes on ECMO, I think it's still reasonable to consider ECMO. It might give me a little pause if I have an ECMO-supported patient that then I'm giving boluses of intralipid too. Again, that'd just be a discussion with the whole ECMO team, and I think needs to be a center-to-center decision. But I will say we've used propofol and clovidipine and other lipid-based drugs with success on ECMO. Here's the back of one of our oxygenators during a case of a patient receiving propofol. This is, again, things get complicated. This wasn't just propofol. This patient had actually HIT as well and thrombocytopenia. But what I'm showing you is a flashlight test where we kind of obliquely shine a flashlight on the back of the oxygenator. And you can see some white streaks kind of outlined by our marker. And that is either fibrin or lipid or something getting adhered to the membrane of our circuit. This patient did fine. It didn't need a circuit exchange or any other intervention. We just watched this. But again, you can see some changes. How clinically important they are is debatable. Other issues related to tox I wanted to mention before we go into the cases. ECMO gives you a great opportunity to do renal replacement therapy if you need to or want to. Here's one of our patients. Again, we're managing with the CardioHelp device as well as a continuous renal replacement therapy module. How you do this is also a moving target in ECMO centers. We much prefer to keep our ECMO circuit, again, the cannula, the pump, the oxygenator, and the return cannula as simple as possible with as few things kind of jerry-rigged or wide into the circuit. If you put your dialysis machine into and splice it into the ECMO circuit, you can take advantage of the ECMO pump to create some additional blood flow. There are some theoretical advantages, but it also puts you at risk for introducing air or infection or other things into your ECMO circuit. So our preference at our shop is to give these patients a separate temporary dialysis catheter at a different central venous site and keep the dialysis circuit separate from the ECMO circuit. One reason is these dialysis circuits for CRRT have a roller pump, which again isn't sensitive to preload and afterload like the ECMO pump is. So they can fight against each other a little bit if you try to put them together. So again, this will vary center to center, but being on ECMO certainly does not preclude using dialysis either to filter toxins or to replace failed kidneys. I wanted to come back to anticoagulation then as another area of controversy within ECMO. There's research ongoing and there's a lot of opinions about if you, and I think it still is standard of care to anticoagulate patients. Is it best to use heparin, which has been the kind of tried and true method monitored by either ACTs or PTTs or what we use at Hennepin as anti-10A levels, or should we be moving more to direct thrombin inhibitors? Here I'm showing bivalrudin as an attractive choice. The DTIs are very expensive, and we haven't made that change. Other centers have. Or I bring up the question of just, are the circuits good enough now? We know these newest ECMO circuits are heparin bonded in the plastic tubing. They introduce some heparin into the filter to begin with. Are they good enough with high enough flows to not spontaneously clot without anticoagulation? So I think in select cases where you're encountering a patient with GI bleeding, or I was talking with one of our toxicologists earlier about the patient with a anticoagulant overdose, for example, who is very prone to bleeding. You don't want to add extra anticoagulant there. I think that's reasonable to not give them systemic anticoagulation during the ECMO run. We've done that in a venous case of ours for 14 days with no anticoagulation and didn't have any arterial venous clotting or loss of the circuit. The gas exchange was still very efficient. So it's an open question and one that I think will be changing in the next 5 to 10 years. Okay, I've been going for about 25 minutes. I want to take a few minutes then and go through a couple interesting cases that we've taken care of here in the Twin Cities and illustrate some of the principles of ECMO that we were going over. So I'll just hop right in. Again, they're not to illustrate the tox principles, which you folks are the experts, but mainly to highlight the extracorporeal support aspects of these cases. The first one I want to present was actually taken care of at another ECMO center here in Minneapolis. We're lucky that we actually have 4 ECMO-capable medical centers here in town that serve kind of the upper Midwest. They each have kind of their own niche, and this one was taken care of at a very busy community hospital nearby that has a good ECMO program focused a lot on advanced cardiovascular support. So they heard about a 23-year-old woman who overdosed on what you can see here, Wellbutrin XL, a total of 9 grams, as well as Depakote ER, a total of 4 grams, we think. The ingestion happened about 8 hours or so before presentation. They came into the community hospital ED just outside in the rural areas around the Twin Cities with the vitals you see here. The patient was hypotensive, mildly tachycardic, and afebrile. Patient was alert, was started on fluid repletion, and vasopressor support was called for. Upon arrival in their ICU at that facility, the patient did have a generalized tonic-clonic seizure and was then promptly intubated for airway protection and sedated with propofol and lorazepam. Discussion with the Poison Center about this dangerous overdose led to recommendation to transfer this patient about 30 miles or so to the receiving ECMO center. This was done by ground and was an uncomplicated transport. Patient arrived, as many ECMO patients do, with lots of lines and tubes. Patient had an endotracheal tube, a ventilator. This photo is not that patient, it's just one I took from the web, but illustrates what this might have looked like. Central venous and arterial access, as well as the ECMO circuit, which came with the patient in the ambulance. On arrival, an EKG was obtained. They had a long QT of almost 540 milliseconds, and resuscitation was continued. So the patient was treated with norepinephrine for hypotension, a bicarbonate infusion before our current shortage. They were loaded with Keppra, and then continuous EEG was used in this case and had some interesting wrinkles later on. On the same day of transfer, after arrival, the patient did sustain a cardiac arrest. I'm showing you the EKGs of this patient. On the top is on arrival at the hospital before the cardiac arrest. And this looks to me like a narrow complex regular rhythm with some ST depression. Down below then is what happened kind of during and right after the code. So they diagnosed a wide complex Brady PEA rhythm in this patient. And with standard ACLS did have ROSC after about 15 minutes, but this patient was in profound, at this point, profound cardiogenic and vasodilatory shock, was on high doses of 5 pressors, and was very close to death. The patient also during this event developed ARDS, and this was a CT scan they obtained after a little bit more stabilization. But you can see here really consolidated, densely consolidated dependent areas of the lung, which is classic appearance of ARDS and wet lungs. That led to refractory hypoxemia. So they actually cannulated this patient for a hybrid mode of ECMO, which is called VAV, and I'll describe a little bit more what that's about. But they wanted the VA ECMO support of this cardiogenic shock and failing heart, but they also put an additional venous limb there to return additional blood to the patient, but that then could be easily converted to VV ECMO if the shock improved but the ARDS remained. So it left them some additional flexibility. And I thought it was a very creative move right off the bat in this patient who is, again, very critically ill. Here's the conclusion of the case then. As they set up their ECMO circuit, again, I mentioned before, you set 2 key physiologic parameters of ECMO to support the patient. You set a blood flow to oxygenate that patient and via ECMO to perfuse the patient. They were able to run the ECMO pump at 4 liters a minute of blood flow, which is good for this size woman. And then they set a sweep gas flow, and this is just oxygen going through the oxygenator that sweeps away carbon dioxide of about 2.5 liters per minute, which would be a standard setting to maintain a PCO2 of 40 and a pH of 7.4. Over the next couple of days then, these vasopressors are weaned off during ECMO support. They were able to convert this hybrid mode of ECMO, take out the arterial limb, and just left the patient on veno-venous ECMO, again, with a functioning heart, but just to support the ARDS. Over time then, again, just several more days, the lungs did improve. They weaned the ECMO as we do on respiratory ECMO, not by stopping blood flow, but by actually just decreasing the sweep gas from 2.5 liters to 0. By having the sweep gas 0, we're essentially just having a sham circuit of blood going outside the patient. Gas exchange is not happening. And with that trial, the patient was able to maintain a good-looking blood gas and hemodynamically okay, so was able to be freed from ECMO completely. The other interesting part for a non-toxicologist like me was at the end of this case, the patient remained deeply comatose, dilated non-reactive pupils, was lacking some brainstem reflexes, but with continuous EEG, they saw a burst suppression pattern that seemed to fit with diffuse brain dysfunction. There are case reports in the situation of people actually be concerned about brain death, but these intensivists hung with the patient, and the neuroexam slowly improved over the next 3 days. She woke up and was able to be extubated. So made a full recovery and was an excellent, I think, use of veno-arterial and then veno-venous ECMO for a complicated overdose with lung dysfunction as well. All right, I'm going to pause for just a minute and get ready to present case number 2 then. I think we're doing okay for time. I want to leave some time for questions at the end. The second case I want to present, I think, speaks a little bit more to the challenges in transporting these patients to get them to ECMO. And this case actually happened in 2 stages, so let me describe what we took here at Hennepin took care of. This was a 45-year-old woman who presented to a critical access hospital in far northern Minnesota, right on the border of Canada. Very small hospital, tiny ED, and reported just an hour previously she had ingested in a suicide attempt 4.8 grams of verapamil CR and just over 200 milligrams of prazosin. You can see her vital signs there. She presented normotensive with a heart rate of 110. That hospital appropriately got in touch with toxicology and recommended to give activated charcoal, and that was done to an awake, alert patient. Then preparations for transport was made. Fortunately, Minnesota can have some rough weather, especially in the winter. This day did not have that, so this patient was able to be transported and came by air from our referring hospital to an intermediate hospital up in Duluth, Minnesota. And Duluth has great medical care there. They have the ability to place patients on ECMO, but typically, at least in this day and age, won't manage them for a long period of time. They'll typically get them to the Twin Cities to an ECMO center, although that is, again, changing quickly. So that's what happened to this patient. She drank her charcoal up in northern Minnesota, arrived in Duluth, and unfortunately had obtundation and had developed shock. They had placed a King airway or supraglottic airway in this patient on that initial transport, and there was some difficulty en route and arrival there in exchanging that supraglottic airway for an endotracheal tube, and there was an aspiration episode, so charcoal aspiration of concerning certainly, but the patient was still supportable, started on vasopressors, and in Duluth then, with the help of a consulting toxicologist there who does a great job, a decision was made to cannulate this patient for veno-arterial ECMO, especially with this severe life-threatening calcium channel blocker overdose. So ECMO was started. The patient at the outside hospital was also started on high-dose insulin therapy, and that was titrated up rapidly. The high-dose insulin management wasn't started at the original hospital because, as I understand it, they were less comfortable with such enormous doses of insulin, and they had a limited supply of dextrose ampules at that hospital. So again, we don't want to get up, to 1 or 5 or 10 units per kilo per hour of insulin without the dextrose. So the patient then was stabilized and transported on ECMO via fixed-wing aircraft to our facility in the Twin Cities. Again, here's the x-ray from arrival at our hospital ACMT. The patient arrived on 2 vasopressors at moderate doses, supported on VA ECMO with a good blood flow rate, and was on a high-dose insulin protocol at 5 units per kilo per hour. The blood pressure on arrival was 90 to 100 systolic, and the patient seemed well perfused. The ECMO course in this patient actually lasted about 6 days, and you can see on the x-ray, I think there's concern for an aspiration event in the right lung especially. There's lots of tubes and lines here. It's fine to have central lines in patients with ECMO. Here we have just a standard IJ triple lumen to infuse medications and get lab work. This is the large venous drainage limb of the ECMO circuit coming up in the inferior vena cava from the femoral vein. You can see how that looks on the x-ray, and that's about the appropriate position. We want the tip of that venous drainage limb pretty close to the right atrium, or if not in the right atrium. The interesting feature of this case for me is we took care of this patient was patient actually developed about 72 hours of complete heart block, and although the cardiac function seemed to improve, ventricular function was improving, the conduction system really took a hit from this verapamil overdose. And eventually we were able to wean off of ECMO, sinus rhythm returned, and the lungs improved enough where we could discontinue ECMO at day 6. The patient made a complete recovery. Talking with our toxicologist here, I was interested in these cardiovascular drugs, especially calcium channel blockers. At very high doses, I understand they're kind of non-selective in the receptors they inhibit, and they can both cause cardiac depression as well as extreme vasodilation. The cardiogenic shock, cardiac depression, is much easier to treat with ECMO. We sometimes struggle a little bit with vasodilatory shock just because if the heart works, the cardiac output is often very high, 10 or 15 liters a minute. And if we're flowing at ECMO 4 to 6, we're not necessarily making up a big fraction of that cardiac output, and the patient is at risk of not being super well perfused, especially in the upper body. All right, to speak more general as I wrap up then, a couple points about when to transfer a poison patient for ECMO. I think it needs to be a case-by-case decision with input from a consulting toxicologist. Early consultation with someone expert like you folks in this is I think, key, and that's what I stress when I speak about this outside of the tox world. It's also important early, and I'll touch on this right at the end, to know your neighborhood and know where you're going to send a patient for ECMO and start to make those transport operational decisions and even dry runs happen before you actually need it, just to make sure things go smoothly. Here's a couple slides showing a geographic distribution of ECMO centers. This is, again, according to our international registry that we submit and many others submit data to. As of 2016, there were over 370 ECMO centers registered with this organization in the world, and you can see their distribution here. It kind of gives you a pause about where you might want to go on vacation next. Here on the right of the screen is research from Pittsburgh that they looked and tried to map out the geospatial distribution of adult ECMO centers in the U.S. and kind of looked at dark orange, lighter orange, and yellow as far as how long a transport to that facility would take. Here we are in the Twin Cities, and you can see we've got rings both showing a 1-hour inter-hospital transfer and 2-hour, but we've got areas of the country sparsely populated, but there where there really isn't 2-hour access to an ECMO center, and would need to be creative in those cases. Just begs the question of, I think ECMO is expensive and resource-intensive technology without excellent data behind it right now. And so it's really important to be thoughtful about organizing a regional system of referral, just so ECMO centers don't keep multiplying and we can give high-quality ECMO care and get volumes to maintain those skills. Here's just the nuts and bolts of transferring a patient on ECMO. In our neck of the woods here, we have 3 main ways to get patients around: ground ambulance, helicopter, and a fixed-wing aircraft. And I'm just showing you and highlighting some aspects of each. The benefits of fixed-wing or ground transport are that weather really isn't a factor. They can transport patients in lots of conditions. We typically go to fixed-wing when the distance of transport is over 150 miles, where ground transport is most useful in an urban or suburban environment. The cheapest option is certainly sending your patient by ground, and the ground ambulance actually compared to the aircraft gives you more space for the ECMO circuit for ECMO team members, such as a physician, nurse, and perfusionist to transport with the patient. You're much more limited in a fixed-wing aircraft to who you can fit in there and then who would respond in the case of an emergency. Ambient noise is a big deal in the helicopter, so you can't hear bubbles in the ECMO circuit, can't hear the patient's heart and lung sounds as you're transporting. And then a downside of fixed-wing transport would be the extra stops. So those have to land at airports and would then need to transfer to a ambulance to get to the receiving hospital. All right, let me then summarize. We're about 40 minutes in, and we'll have certainly time for discussion, I hope. I wanted to illustrate for you just 3 simple components of all ECMO circuits, just so it's less intimidating when you're in your ICU and seeing these patients. Every ECMO circuit has a pump, a membrane oxygenator where the magic happens, gas exchange happens, and then large bore cannulas. And it's really where those cannulas are draining blood and returning blood, which determines what kind of support you're giving to your patient for heart and or heart and lung failure. There are 2 main kinds of ECMO I highlighted, VV and VA. VA ECMO is the most intense. It's for cardiac and respiratory support. And then really choosing patients for ECMO, we're looking for people, and the buzzwords for me are potentially reversible disease and a critical illness refractory to conventional management. Critical poisonings, I think, could be ideal candidates for ECMO and are ideal candidates for ECMO, especially the drugs we mentioned. And really, any patient that has poisoning syndrome that would cause cardiogenic shock, if the mechanism is plausible, I think it's reasonable to think about ECMO as a rescue therapy or in your treatment and support paradigm. And the key is getting to an ECMO center or getting to an ECMO circuit in time. So fortunately, medium-sized hospitals in less populated areas, some have CV or vascular surgery capability and have ECMO circuits, can cannulate patients, but then would plan to send them right away and not keep them at that outside facility. That's a system that's worked well in Minnesota and other places, and I think one we should really organize on a state and national level. So with that, I'll wrap up and just want to leave my contact information if there are any questions or future work we can do together. Thank you very much for your attention.
Matt, thank you so much. Really outstanding survey of the method itself and then applications to what we're interested in toxicology. I have a couple of chat-based questions I'm going to translate for you to allow you to discuss, as I remind everybody else that I'd love to have them raise their hands and have direct dialogue with you. Sorry, you can actually hear outside one of those helicopters potentially flying in another patient right now for you to do this. Questions are about in what scenarios ECMO will compensate essentially completely or mostly for the need for pressors, and whether or not in the issue of vasodilatory shock there's a potential worsening of the situation or anything else you can do to monitor the situation more closely. There are questions about the potential role for echocardiography in these cases at the same time to try to determine what you've been able to correct and what you haven't. So just some comments on pressors and echo and things like that, if you would, in management.
Sure. I think all these patients in cardiogenic shock, especially poison patients, get vasopressor therapy, and that's very appropriate and widely available. When we make decisions about who is a candidate and who should go on ECMO and how fast they should go on, a lot of it has to do with how well are their hemodynamics supported with our typical critical care like vasopressors. High-dose insulin therapy is an alternate inotrope. And how well they're responding to it. So to touch on the echo question first, I think it's extremely valuable to monitor that patient's contractility and cardiac function with echocardiography. We know, especially on high-dose insulin therapy in the ICU, that the heart rate or even the blood pressure is not the whole story, because ionotropy and contractility really will help your perfusion. So we use different modalities here at Hennepin, including tissue oximetry, cerebral oximetry, and then either transthoracic or transesophageal echocardiography to determine how we're doing on the resuscitation. Can help guide fluid therapy too, so extremely useful. I highly recommend it. And just another plug for ECMO is that as we wean veno-arterial ECMO, we actually do serial ultrasounds at the bedside as we decrease the blood flow and see what function is returning in the heart. So if we think the patients improve, maybe they metabolize their poison, we'll actually turn down the ECMO flow to a liter a minute or so, and then actually watch directly for the next 5–10 minutes with ultrasound to see how the patient's heart has recovered, as well as look at their hemodynamics and gas exchange. So echo is a good thing. The vasopressor question is an excellent one. A lot of vasopressor use, often in extremely high doses, which are needed to overcome these adrenergic blocking drugs. We use ECMO to save lives. If someone's really at the point of dying, they're definitely a candidate for ECMO in a poisoning situation. The other decision-making and calculus we take into account is what damage are those vasopressors doing? I think this might have been underlying the question, but we know that running, epinephrine and norepinephrine at very high doses can make limbs ischemic. It can cause gut ischemia. There are big problems that are collateral damage. And boy, if we can spare them some vasopressor support by using VA ECMO as an adjunct, maybe a little earlier than we would if the patient's not absolutely crashing, I think that's a good thing. And we've made decisions along those lines in other pathologies already. So I think that's a thing, and it just speaks to the fact of getting in touch with an ECMO center early in a case and maybe going through a regional poison center or a toxicologist to really make those decisions about when can we get this patient in an ECMO-capable center. And then the vasodilatory thing is really interesting to me, and analogous condition is septic shock. So some people have written and studied and are interested in using VA ECMO for septic shock, thinking that the heart often is hyperdynamic. There is septic cardiomyopathy, but apart from that, a hyperdynamic heart, a vasodilated patient, putting them on VA ECMO, it has been done successfully. With any ECMO intervention, it's hard to know, boy, how would they have done without ECMO? Is a big question, but physiologically, it just makes a little less sense to me than a failing pump on VA ECMO. I think it just leaves us a little bit more work and makes it a little more likely that the patient's upper body, head, and coronary arteries would be less perfused than their legs in that kind of condition. And sometimes in very hyperdynamic patients with vasodilation, say a patient on ECMO, VV ECMO who gets septic, we'll sometimes even give them esmolol or a drug to decrease their cardiac output and try to make our ECMO flow a bigger proportion of their cardiac output to better oxygenate the patient. So complicated answer, but a great question.
Thank you very much, Dr. Brett Charrington, any follow-up comments or questions to that summary? I think I was trying to translate some of what you had written. I've got you unmuted now if you wanted to talk.
No, I think that covered it pretty well. So it sounds like if you've got a patient on multiple pressors, once you get them established successfully on ECMO, you can theoretically just turn off those pressors and let the ECMO pump provide the flow, if I'm understanding correctly.
Yeah, this is Matt again. I think, can you hear me? Yeah. That is correct. Yeah, we find almost universally that on ECMO patients have decreased pressor needs. Often their pressors don't go away completely. I think I illustrated a case where they did, with I think it was just the natural history of the overdose. But in other conditions, cardiogenic shocks, there is some pressor need, and it's typical to have a VA ECMO patient on low-dose norepinephrine, say 0.1 or 0.15 mics per kilo per minute during their ECMO run, just to tighten up their peripheral vessels a little bit. But pressor needs go way down on ECMO. And, the easiest heart to support with ECMO is actually the arrested heart, because there the cardiac output is 0, and all of the blood flow to the patient's body is being sustained with ECMO. And so in their, sedated and paralyzed state, if you can get 4, 4.5, 5 liters of ECMO flow, that's a fine cardiac output for that patient, and you kind of take their heart and lungs completely out of it, analogous to what they do in the operating room.
Very nice. So Matt, just as a sort of a follow-up related to some of these issues and the one case you presented, you talked about that second tox case in which it was very clear that you were going to be facing pulmonary damage and complications in addition to the cardiogenic issues, even in cases where there isn't charcoal aspiration. We will often see patients have significant ARDS as a complication of a severe overdose. Do you recommend the idea of considering a VAV circuit right out of the gate for any situation where you do expect you'll probably have both cardiac and direct pulmonary problems, because the timetable of resolution of each of those two issues doesn't usually correspond? Often the cardiotoxicity will sort of, you'll be able to pass through that faster, and then the ARDS will linger much longer, so it's nice to be able to control two separate circuits. Does that make sense?
It does, yeah. I think there are a couple issues that we bring to bear on that. I think the expertise of the ECMO center is important, so you've got to be able to have a cannulator and a perfusionist and a nurse who are capable of being creative in the hybrid mode they use. VAV has a lot of advantages just in kind of the exit strategy from it, but it takes longer to get somebody on because you don't want to start flow until all those cannulas are in and you've got it all wired together. So our approach in this second case, our meaning the approach by the excellent team up in Duluth, was to just crash that patient onto VA ECMO solely, because we know that supports lungs and heart, and then let the dust settle, because it is easier to back off from VA to VV than it is to go the opposite way. So I think either approach is okay, and you just have to rely on institutional expertise. There are patients with lung injury that can come off of VA ECMO right to the standard ventilator, even though their lungs are still damaged. They don't need VV ECMO, and that's a difficult decision to make, and one we don't have a lot of data around. It's kind of a dealer's choice whether you use VV or you just decannulate completely and manage them with ARDS settings on a ventilator.
Makes sense. So one other related question, as far as you know, in the interface between ECMO and the tox world, any discussions about just VV ECMO for taking care of patients who have a pulmonary toxic exposure, where the lung problem is the central problem, and you're not looking at a need to bypass the cardiac aspect of the circuit? VV ECMO for a lung toxicity exposure, has it been discussed? Has it been reported? Do you know?
Yeah, I'm aware of case reports and case series of using VV ECMO in a poisoning situation, whether it's inhalational or hydrocarbon kind of things, or aspiration event or that kind of thing. I think something we share in critical care and emergency medicine and toxicology is aspiration. I think we have to love it to do what we do because it happens so much. And so I think that is a thing, and I think in that case I'd probably approach it much like I would other causes of ARDS, like pneumonia or sepsis or pulmonary contusion, and make decisions about, hey, how compromised is their gas exchange? I didn't mention it in my talk, but we have some specific criteria we look at, especially that PaO2 to FiO2 ratio in finding out who's going to benefit the most from ECMO. These patients that would have, more than 50% predicted mortality, but less than 80 or 85%, so we don't put people on with no chance. Those are the cases we're looking for, but definitely veno-venous ECMO is simpler, it's easier to manage, and in general has better outcomes.
Thanks. So we're getting a little bit close to time, but we've still got a couple more minutes. If anyone else has a question they'd like to pass along in text or even better dialogue with Dr. Precker, I'd be happy to bring you in and unmute you as soon as you raise a hand. Not seeing anything else coming through. The only other issue, I guess, is the practicality issue. Matt, the devices themselves, although expensive and the use is expensive, they are small and portable. Do you expect that we're going to see ECMO availability at a lot of different sites and size hospitals, despite the fact that at this point it's primarily confined to the tertiary world? It seems like there may be a potential to roll this out because there's going to be a desire to have it available for a lot of other cardiopulmonary patients, and then what that would mean for toxicology is availability for our cases too, potentially. Do you think it's actually going to happen, or is the expense barrier going to be too significant for it to really be rolled out in a more general way?
Yeah, thanks, JJ. I think that the way that technology's advanced over the last 5, 10, 15 years, I think if that continues, this is going to be much more widely available and able to be done safely in non-kind of specialized ECMO centers. I think each hospital has to, who starts a program like this, has to have a minimal case volume, has to do a lot of training, has to rely on medical simulation and other things we do here at Hennepin and other places to kind of maintain our instincts and our sharpness in these cases. And then, you know, has to have the financial commitment to support these patients because it is an expensive thing for sure. There's, in our ECMO meetings and national meetings and things, there's a lot of exciting ideas about using ECMO in place of a ventilator in the first place, doing no additional, you know, pulmonary barotrauma or ventilator-induced lung injury. That's a thing. Maybe portable or wearable ECMO where a patient could be up walking around. You know, there's a lot of, the frontier of ECMO is really exciting, I think. You know, there's pumpless ECMO where you put it in an AV configuration. You use the patient's blood pressure alone to generate, you know, 1 or 2 liters of flow to get rid of carbon dioxide and a COPD exacerbation, for example. A lot of new applications that I think we'll read a lot more about in the coming years, but are still 5, 10 years away.
Thank you so much. Again, any last second comments? We do have a couple minutes before the hour. This has been a remarkably useful survey, and it's very helpful for us to have a good sense of what the technology is, where it is, and what the tool looks like, and what the practicalities are. So if we have the urge, either at a distance or running to an interesting consult, to make a suggestion to sort of compensate for someone's pump and their oxygen delivery system, we know what we're getting into, and we know what we're asking of our personnel and of our primary teams we're asking help from. So thank you so much for framing the current state of the art and the places where we might be headed with this technology. Thanks everybody else for attending. As you always do, I'll use the last 2 minutes here before we close to put out a pitch. If you meet anybody in your own shops or nearby, just like we've had the great fortune to do here up in Minnesota to meet Dr. Precker, please push the name along and their ideas and expertise onto the stage of our webinar series so that we can disseminate knowledge and make contacts like this, and perhaps even bring folks into the fold to have as associate members in the college. Remember that we're looking to expand membership in ACMT and have it be easier for associates to join us and partner up in our work together. And so we're going to try to recruit Matt to join us and come to our meetings and talk about critical care toxicology more often. And maybe we can use this as a recruitment tool for other experts out there too. So we'll plan to see you again second Tuesday in August. And we, again, welcome any recruits that you've got. Take care, folks, and have a good balance to your week. Thanks again, Dr. Precker.
You're welcome.